Okay, well, let's get started. Welcome everyone to the IARS virtual education webinar, Obstetric Anesthesia Quality, How to Measure It. The webinar has received no commercial support. There we go. And it's sponsored by IARS. The IARS supports anesthesia research and education with the overarching goal of improving patient care. This is the organization's mission and vision. IARS offers many benefits to its members, including monthly issues of Anesthesia and Analgesia, access to the online member community, discounted registration fees for the annual meeting. To join or renew, visit the IARS.org website. For those of you who are joining us from international locations, the IARS provides free resources for the global anesthesia community. Free IARS membership is also available for fellows, residents, medical students, and others in training. And you can visit the membership website to find out more. The IARS membership committee seeks your feedback on how IARS can provide you with the most meaningful engagement experience. So scan the QR code on this slide to take the survey for a chance to win one free annual membership or one free annual meeting registration. In case you missed the 2024 annual meeting, on-demand recordings are available for purchase. And please save the date for the 2025 meeting, which will be March 21st to the 23rd in Honolulu, Hawaii, presented by IARS and SOCA. Abstract submission is now open for the 2025. Oh, these are out of order. For the 2025 annual meeting. After the webinar today, you can join speakers in the IARS Doc Matter community to continue the conversation. And for the upcoming webinars, you can visit IARS.org to register. As the presenters are presenting, please think of questions. We're hoping for some time for discussion at the end of the presentations today. And you can enter those questions in the Q&A box within Zoom. So we'll be monitoring that throughout the presentation. So without further ado, today to discuss obstetric anesthesia quality, how to measure it, we have three outstanding presenters. Our first will be Dr. Marcus Zakowski. He is chair of the ASA Committee on Obstetric Anesthesia, as well as vice chair of the ASA Committee on Quality. And he'll be talking today about the ASA perspective on how to measure quality in obstetric anesthesia. Next, Ruth Landau will present on the SOAP perspective with a focus on centers of excellence, what makes them excellent. She is chair of the SOAP Centers of Excellence Committee and our incoming editor-in-chief for the International Journal of Obstetric Anesthesia, so a true expert in our field. And finally, Kelly Fedoruk will draw from a narrative review that will be included in the December issue of Anesthesia and Analgesia, which will be the themed issue on obstetric anesthesia quality. She's the quality improvement lead for the Division of Obstetric Anesthesiology and Maternal Health at Stanford University. So with that, Dr. Zakowski.
Yes, thank you, Dr. Mhyre, for the introduction. And we're going to talk about quality metrics in OB anesthesia. I have no disclosures. So quality metrics, not a hard choice. We're going to learn today what some prospective potential quality metrics you can use, domains of quality, and how can it help improve your practice. If you're working in the main OR, you would expect them to be tracking things like intra-op death or reintubation in PACU, and the OB department to be following massive transfusion, and the rate of cesarean section. So why should we take the effort to do quality metrics? Well, we know most obstetric deaths are preventable, as well as most hospital harms. Fortunately, anesthesia mortality, we've worked hard as a specialty over the decades, and it's very, 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 very low. But we are at the crux, at the juxtaposition of what goes on in the OR, what goes on perioperatively. And as we've learned the last 10 years, that has significant influence to postpartum period and even beyond. As Deming said, what gets measured gets improved. He was really the father of quality improvement and helped Toyota significantly after World War II, and was the inventor of Plan, Do, Study, Act. As AHRQ, governmental agency, suggests, the domains of quality include it being safe, effective, patient-centered, timely, efficient, and equitable. So you can choose to have a metric which is an outcome metric. So for instance, your unintended dural puncture, otherwise known as a wet tap, rate should be X%. Or it could be a process like we check all patients for possibility of having a headache the following day or two. And then if it's particularly if it's an outcome metric, it's a question of, well, what's the right number? What's the correct benchmark? So ASA, has supports a database, AQI. There's MPOG. A lot of hospitals now are using Vizient to compare to other hospitals. A recent survey in the UK said 30% of anesthetists felt they had insufficient resources to even analyze the relevant data. And the Obstetric Anesthetists Association also came up with some suggested metrics for provision of service, quality, and outcomes. So choosing metrics, the ASA Committee for Obstetric Anesthesia came up with some metrics in the process. It's really intended to help you, the individual practitioner, and to account for variation. Things are very different in my hospital compared to your hospital, and even local issues. And remember, these are voluntary. These are not mandated or required, just suggested. So we assigned a working group. They did a bunch of homework, looking at ideas, what's the scientific validity, the feasibility. We talked about what would be variations in practice, what could be accepted by people practicing in the community. And then we got full committee input, and then suggestions from the board of directors, and ultimately final wordsmithing and approval from the House of Delegates. We came up with 6 different suggested quality metrics, and we'll go over them one by one. The first would be mode of anesthesia for cesarean. So most commonly, people use what their general anesthesia rate for cesarean delivery. This would be an outcome metric. So you would have to pick, well, what's the right benchmark? The SOAP, Sears Complication Registry study said 5.6% was the rate of general anesthesia use. SOAP Center of Excellence suggests less than 6. Brigham even at one point said their rate was as low as 1%. So it really depends on the culture at your hospital, the type of caseload, and you may want to even dissect that out and track different rates for, is it an elective cesarean section, or is it emergent? Or was it a conversion from regional to general? And then that creates secondary consequences and concerns of, well, how much IV sedation are you giving? Or you could change it and pick a process metric. We know neuraxial hypotension is very common, particularly after spinal anesthesia for cesarean delivery, and that therefore this is our second quality metric. The incidence is high, up to 74%, and it can have maternal and fetal impacts. Best practices would be to use a vasopressor infusion as well as to co-load fluids. And metrics would be check the blood pressure frequently between neuraxial to delivery, to use a vasopressor, and to gain what I call tight control, or 10% within baseline. We know that opioid consumption leads to more opioid consumption, and needing to use less is an indirect measure that you're using good multimodal analgesic protocols. Very sadly, it's been shown that 1 in 300 opioid naive patients having a cesarean section will be using opioids later. And that even 2% are using it 3 months later. We know that educating pre-surgically will help reduce post-op usage, as well as involving patients in the decision of how much opioid do you want to go home with. That leads to the third quality metric, opioid consumption post-cesarean. And there are a couple different choices you can have on doing this, whether it's the percent of people receiving opioids postpartum, the morphine milliequivalents consumed. The more you consume, the more likely you're probably going to be still consuming opioids when you go home. You know, whether they got the education, and then probably very important would be percent of people getting sent home with discharge prescription for opioids, and how many morphine milliequivalents that is. We know when a lot of times people wait to ask for the labor epidural, whether for correct or incorrect reasons. But we know that once people want it, usually they want it now. So delays in responsiveness lead to patient dissatisfaction. Royal College of Anesthetists, they suggest it be attempted to be request to being there within 30 minutes and certainly within an hour. ASA and SOAP have no specific time requirement, but this in particular is very dependent upon local staffing, resources, what's the volume of deliveries, are there other emergencies either in OB or even in the main operating room going on? And that leads to quality metric number 4, sort of the responsiveness. You could choose to use time from patient request to someone showing up and arriving, or perhaps percent of patients who experienced a delay or who never received it, and tracking the reasons for the delay. Post-dural puncture headache, you know, published studies show there's a 10-fold difference in the unintended dural puncture rate from teaching institutions to private practice. And over the last several years, we've seen that unintended dural punctures carry increased risk postpartum for longer term things. It's been associated with chronic headache, rare, but increased association with cortical vein thrombosis. If you're in a lot of pain, it's going to be more difficult to breastfeed, and even depression and PTSD postpartum. This leads to quality metric number 5, post-dural puncture headache. So most people feel this is the one thing we can control to some extent, but you know, what percent of unintended dural punctures, also colloquially known as wet taps, what's the overall post-dural puncture headache rate? And you may, even if you have a big enough service, want to divide that into separate numbers for spinal placement for C-section, epidural, or combined spinal epidural, DPE. Another possible is from time someone has a symptom, how long it takes to be seen, and then spinal needle type engaged. Although if you're consistent that everybody is using the suggested spinal needle type engage, then it's not useful as a metric because there will be no change over time. Of course, when someone wants labor epidural for pain relief, they want it to work, as do we. So lack of desired clinical effect. Again, Royal College of Anesthetists suggests 45 minutes. There's no time specifically mentioned by ASA or SOAP. In the SOAP Center of Excellence, as Dr. Landau will talk about in a few minutes, really it's about making sure you regularly check on your patients and their regular assessments for pain relief, motor block, sensory level. And studies have shown early replacement of a labored epidural, which isn't working so well, will decrease your failed neuraxial to general anesthesia and decrease your overall general anesthesia rate. This leads to quality metric number 6, talking about labor epidurals and possibly the replacement rate. So metrics could be time from neuraxial to relief, making sure they're getting frequent assessment. And this doesn't have to be by the anesthesiologist, CRNA or CAA. Remember that A1 in their 2020 guidelines say the degree of motor block, sensory level, and pain relief should be documented by the RN hourly. And of course, it would be good to track, what % of labor epidurals get replaced and how many fail when you want to go to cesarean. Again, just as a comparison, the Royal College of Anesthetists talked about quality improvement in 2020. 13% of their epidurals of members surveyed were replaced, so they suggested a goal of less than 15%. And adequate pain relief within 45 minutes from the start of the neuraxial, with a goal of almost 90%. SOAP Center of Excellence has certain metrics, again, so that those are more an idealized, what we would like to be doing for everybody. That makes it a center of excellence, and Dr. Landau will be talking about that momentarily. So what are the benefits of quality metrics, right? If you track what you're doing, then you have knowledge, and you can see where you can make improvements and changes and improve patient outcomes. Here, this just reiterates when you give someone a prescription post-cesarean and they take it home, that correlates with being more likely at 1 and even 3 years later to still be taking opioids, whether it's the number of days supply or if you get a refill. And we can see the benefit of having tracked this is that even though there was about 2% incidence of persistent opioid use, by seeing the problem and becoming more cognizant of it, we've dropped that rate by about 50%. And of course, it can help you to track disparities and try to improve those. There was a recent study that showed that Black women received general anesthesia for cesarean section at a higher rate than white women, but that if they had an epidural in place, there was no difference. So that identifies opportunities for improvement in education and providing the service. So picking the quality metrics. As we said, and Dr. Fedoruk will talk about a little bit later, there are always unintended consequences. When you emphasize one thing, like the general anesthesia rate, people are going to be giving more IV sedation and trying not to get dinged. Or could be a fear that, oh, you're not going to report a wet tap because your wet tap rate is too high. So as I mentioned, if you're already doing something almost 100% of the time, there's no point of using that as a metric, like we already use pencil point spinal needles. In a recent letter to the editor, little paper, process outcomes were used more often than outcome metrics. Anyway, the ASA, our committee worked and the ASA passed statement on quality metrics. So just do it. It's there for you to use. It's free. Adapt it to what's pertinent in your local use and use it. This is an example. Each one of the 6 proposed metrics has a much fuller table than I have time to go into about the rationale why we picked it, some of the background, some suggested best practices, and then some metrics and how you can tweak it to be more useful to you as an individual at your local institution. Thank you very much and hope to see you in Philly.
Dr. Landau, do you want to go ahead? And I have one question in the chat, but I'm going to hold the questions until the end.
Thank you so much for the kind introduction. Good afternoon, good morning. I see people from around the world have joined us, which makes me very happy. So my title for this presentation is What Makes It Excellent? So I was looking into the definition of excellence. Obviously, we all, want to achieve excellence, but I looked back and found this quote from Aristotle. Excellence is never an accident. It is the result of high intention, sincere effort, intelligent direction, skillful execution, and the vision to see obstacles as opportunities. And so excellence can be opposed to perfection. Excellence versus perfection, one could look at it as excellence paving the way for improvement, as mentioned by Dr. Zakowski, that it's a constant process. And perfection may actually pave the way for stagnation, striving for something that is not achievable and, sort of being fixated on a myth, which might limit creativity and innovation. So I want to go briefly about why SOAP decided to embark on this journey, which is a continuous one. But this was in response to the newly defined mission of the society, which is to advance and advocate for the health of pregnant women and their babies through research, education, and best practices in obstetric anesthesia care. So how did SOAP design the COE designation and the process? What is measured? What's happening now, and what's next? So why? It seems pretty obvious, but obviously wanting to recognize programs that demonstrate excellence. But obviously not just that. It's not about, tapping one's shoulder saying that there's several institutions that provide superb care, but it was also to set a benchmark for optimal care, surrogate for quality metrics for institutions, and very importantly, to promote the subspecialty of obstetric anesthesia care and provide a blueprint for those striving to provide excellent care. So to recognize, promote, and facilitate excellence amongst many types of facilities with different delivery volumes, and that became something obvious throughout the process. Since its initiation in 2018, the Centers of Excellence subcommittee welcomes applications from a wide range of institutions. And it's going to be a recurrent theme throughout my slides, from low to high volume centers, community centers, academic centers, and tertiary referral centers from the United States, but also worldwide, recognizing that excellence might not mean the same thing for every institution, and it needs to be adapted and tailored, not just to the institution, but also to the patient population that institution serves. So we did a lot of soul searching, trying to see why would institution want to apply for the designation. Obviously the prestige, the quality indicator with national and international recognition, but there are also direct benefits to provide an incentive and justification to implement best practices, do the right thing, but be recognized for doing it. Also a marketing tool for the hospital, the delivery unit, and the anesthesiology group, and also to join a COE network, sharing protocols, having research collaboratives. I'll talk about it a little bit. Also the indirect benefit of recruitment and retention, facilitate recognition with the ACOG level 3 and 4 maternal care centers. So that's very important. Obviously, no anesthesia group works in a vacuum. There's always the obstetricians, and communicating and sharing protocols and resources and gaining the leverage to do so through the ACOG level of maternal care is very important. Also, income and cost savings, useful in negotiation with payers and hospital, increasing patient volumes. I don't know that we know that we've done that with the designation, but this is certainly something that we can look into one day, and potential risk management and malpractice insurance reduction. And so we've heard, this is quotes from people who have applied. So institutions and people who have applied told us that the application process has its own benefits and rewards. It's allowing institutions that didn't necessarily have a big culture of quality assurance programs. It allows them to learn and know how to review, audit, and analyze their practice. It allows them to gather all stakeholders, recognizing that it's expertise of all that is required to achieve excellence. So the obstetricians, the nurses, pharmacy, hospital administration, and other interdisciplinary collaborations. And also that the application itself allows them to implement changes through a quality assurance program. So how did it all happen? So this is the fruits of brainstorming of a task force that was initially launched by two individuals, Dr. Jill Mhyre, who's here, and Dr. Brendan Carvalho, who was chairing the subcommittee until last year when he handed this over to me. So in 2008, the desire was to gather a group of individuals who cared about obviously patients' outcome, quality improvement, quality assurance. And so at the same time as the process for the designation was designed, was also designed what the criteria would look like. And for that, a subcommittee that was included diverse people from private practice, large institutions, small institutions, the academic institutions, obviously gathered to try and identify all aspects of obstetric anesthesia care and definitely incorporate evidence-based recommendations, some of which were not all available in 2018. So as I mentioned, it's a dynamic process and it's very humbling and it's a very nimble process. The criteria are reviewed and updated annually. And the very important is that the process to not only update the criteria, but also to review the applications is extremely reproducible. It is rigorous, it is transparent, and it really follows, I would say, a process of reviewing a research article. So institutions submit their application. It gets reviewed by 3 people that are selected so that they don't have a conflict of interest, that come from diverse institutions. And every criteria in the application is reviewed by these 3 reviewers. It then generates a report. The report is then presented to the subcommittee. It is then discussed, and then the person, the lead who submitted the application, gets sort of a list of points and issues and concerns that are potentially addressable, some that might not be addressed, but with a request to address them. And there's a back and forth of a rebuttal before the decision is made, whether an institution will receive or not the designation. And the process itself takes between 6 to 9 months. So what is measured? The metrics. So same thing, no surprise, some of the same metrics that Dr. Zakowski presented. There are 3 of them here. So the general anesthesia rate for cesarean delivery, the neuraxial labor analgesia replacement rate, which was a metric that was added subsequently. It wasn't there in the first blueprint, and then the accidental dural puncture rate. And then there are domains, and those domains are extremely important and sort of communicate with each other. One of them, and I highlighted in yellow those that I want to talk about briefly, is personnel and staffing, the coverage model, the supervision model, depending on what the institution is and the size of it and whether it's a training program or not. We're asking for very specific questions, and it's really not numbers. It's not just what's your general anesthesia rate, but it's tell us about our institution. Same for equipment, protocols, and policies. And we're actually asking for the institutions to submit the protocols. And we don't want them to just, send us the latest SOAP consensus statement. We want them to show us how this has been integrated into their specific institution and labor room. We do ask about labor analgesia practice, all of it. What's the epidural analgesia rates? What is given? What are the solutions? Same for cesarean delivery management. We also ask for any protocols and recommendations and guidelines implementation, and what is the quality assurance and the patient follow-up, with many questions looking at how complications can be evaluated early and what the follow-up is, particularly for accidental dural punctures. And then I put it here, but there's certain criteria which we initially called essential, which we're renaming now core elements, which the applicant knows which one of them are essential and which ones are not. And when it is essential, we always explain why and we provide references. More and more, we have now SOAP consensus guidelines or interdisciplinary consensus guidelines that SOAP has participated in that provides the information as to why these elements are essential. And we emphasize throughout the application that there's variability in practice that is expected, potentially encouraged, recognizing that bigger centers, smaller centers, and centers that are referring patients rather than referral centers might have different practices and different resources. And when a center is a referring center, we ask for what are the triggers to refer a patient, because it might be great that they're able to refer patients, but they need to know when this needs to be done. So the metrics, general anesthesia, I'll go over it briefly. We talked about it already, but I want to explain, let's go to the next slide. I want to show where the numbers came from, because it's not just a number in a vacuum. Obviously, this was based on data, which today might seem a little bit outdated, but the general anesthesia rate from the OB anesthesia workforce survey from 2011 showed that based on the institution size, was between, for elective cases, 3 to 19% in larger centers. And then from the NACO registry, we could see that overall the general anesthesia rate is in the order of 5 to 6%. And when it is emergent, it is higher. And there's a lot of questions about whether this is an absolute number. And of course not. The most important is to try to avoid or prevent avoidable general anesthetics. There's now a lot of data and a study in particular that shows that anesthesia-related complications increase, but not only anesthesia-related complications, but they increase in the setting of an anesthetic that didn't need to be a general anesthetic. And so when an institution has a GA rate that is above, we always ask why and what are the interventions that are undertaken to try and reduce that unnecessarily high general anesthesia rates. Talking about labor neuraxial analgesia replacement rate, the importance of replacing an epidural that isn't working is exactly for that reason. If a patient has an intrapartum cesarean delivery, we don't want the cesarean section to be occurring with an epidural that didn't work, that could have been replaced, for the precise reasons that it either will result in pain during cesarean delivery or a general anesthetic that could have been avoided. Next slide. So successful extension of labor epidural analgesia to cesarean anesthesia is a process. We need a dedicated team. We need the knowledge of what progress of labor is, the block quality towards optimizing block quality, communication with the obstetricians, and having awareness that the patient might be headed to the operating room. And this is how this can be achieved, is through really communication between the obstetric anesthesiologist and the obstetrician. Next slide. We can see that there have been several studies now showing that staffing and coverage can work towards reducing the rate of general anesthesia when the anesthesiologist is either more experienced, more skilled, or is dedicated to the labor floor rather than being doing an appendectomy in a different floor. That has been shown in several studies as a way to prevent unnecessary general anesthesia for patients who had an epidural in place. Next slide. So the epidural replacement rate is actually an indirect measure or direct measure of active management of labor analgesia. And so the rate that was chosen as a marker of excellence, which is 2 to 6%, was based on retrospective studies where there was a rate between 1 and 13% that was reported. And so something in the middle of the sweet spot, not too little, not too high, was chosen. Next slide. We'll talk briefly about the unintended dural puncture rate. There's been a lot of data on that topic, and more than where the sweet spot is for the neuraxial replacement and labor analgesia replacement rate. So initially there was a meta-analysis published in 2003 that showed that the unintended dural puncture rate is 1.5%, compiling many different studies. Since then, there have been additional studies showing that the rate is really between 0.4 to 1.6%. And another way of looking at the unintended dural puncture rate is evaluating the post-dural puncture headache rate, and two studies that also showed that it's less than 1%. So this is how that metric was chosen based on evidence. Next slide. So personnel and staffing, very important. We mentioned already, we want the leader of a SOAP Center of Excellence to be an obstetric anesthesia fellowship or equivalent trained physician. We want core staffing with obstetric anesthesia training, ongoing staffing education, adequate supervision, which is very important in the training institutions, in-house 24/7 dedicated coverage, and the ability to mobilize backup that is relevant for institutions with either a very high volume and not many anesthesiologists in-house, or in very low volume institutions where it's important to be able to call for help. Next slide. So where are we now? So as I mentioned, we started in 2018, and every year there's been something new, either added or refined or fine-tuned, new concepts. As I mentioned, the epidural replacement rate was added in 2020. And every year we see, first of all, based on responses that we receive or data that we gather, that there's the need to refine the criteria. In 2022-23, we added several additional criteria: opioid-sparing strategies, protocols for opioid use disorder, pain during cesarean delivery, which is a very important topic right now, and also what are the initiatives in an institution to promote diversity, equity, and inclusion, and the fact that we're now recognizing a wider range of institutions, and the designation has a two-level designation, either an academic tertiary referral center or being a referring center. We also offer webinars and consultations, and it's really a process for those applying. When they need help, we help them throughout the process. So I just put it here, a lot of information, but we follow and offer access to the recommendations, and particularly those of the National Partnership Maternal Safety Bundles with their 8 patient safety bundles, and our own consensus statements. There are now 7 and an 8th one that is about to be published on opioid use disorders. So this is my last slide. What's next? We will continue to reassess the metric, focusing on patient-reported outcomes. Again, evaluate the intended and unintended consequences, provide toolkits for institutions to report, analyze outcomes in a standardized manner, provide toolkits for QI implementation. And we just launched now the ability to actually apply for information within the applications for QA research, or to reach out to centers who have the designation, who are willing to participate and be part of the COE research network. And I will end up by saying that not everything that can be counted counts, and not everything that counts can be counted. Thank you.
Thank you, Dr. Landau. Dr. Fedoruk, bring us home.
All right, thank you, Dr. Landau and Dr. Zakowski, for those excellent presentations. As mentioned, I'm coming from Stanford University in California, and I am the QI lead, and I am going to talk about moving forward with QI with these metrics. Next slide. I have nothing to declare. Okay, so why do these OB quality metrics matter, and why should we look at them with a critical eye? I know that this is an international audience, but most of you will be well aware that we are in the midst of a maternal health crisis in the US. We really can't go a day without seeing a major news outlet reporting on this. It's made its way into the mainstream dialogue, and the public is holding us accountable for this. Next slide. The good news is we do have perhaps some answers or some solutions. Some of you may be familiar with the California Maternal Quality Care Collaborative, which is a multidisciplinary group here in California that advocates for maternal outcome improvement, that was formed in 2006. And you could see on this graph of the MMR, the maternal mortality ratio in the US, that there was a sharp decrease in the MMR in California after the advent of this group in 2006. We saw the MMR decline fairly rapidly while it continued and continues to rise across the US. So how did the CMQCC do this? Was it a matter of novel, medications, tools, building new hospitals. It was really based on these quality improvement toolkits that you see listed on the right here. These were targeting very basic actions surrounding education, crisis resource management, emergency preparedness, and really drove home that quality improvement is at least one way to close this gap. Next slide. So more and more, the word quality is becoming a buzzword, and the introduction of quality metrics by our national and international organizations is falling into place with the larger efforts that our subspecialty is making as a whole. But how do we best use these metrics once they've been published and delivered? And are there some important things to consider when we're bringing them home to our institutions? So over the next couple of minutes, I'm just going to explore some of the caveats, nuances, intricacies, and perhaps some cautionary tales when it comes to quality metric use and analysis in obstetrics and obstetric anesthesia. We'll discuss why context matters, why we should be using an equity lens when it comes to quality metrics, as we should be overall in academia, the safe interpretation of our data, and how to plan the next steps once we've decided and used our metrics. So Dr. Zakowski and Landau both presented on the different metrics that the ASA statement and the SOAP COE criteria have utilized, highlighting the differences between outcome metrics and process metrics. And they alluded to another measure and another metric, but I'm going to highlight it here. And this is the concept of a balancing measure. This is a definition from the IHI. A balancing measure or metric is used to ensure that changes made to improve one part of the system don't negatively impact another part, and they offer a way to monitor unintended consequences by checking the effect of the change in different parts of the system. So balancing measures should be anticipated when improving our outcome metrics, and they're often a good reason to highlight the use of process measures, as I think they both alluded to. So what does this mean when we're wanting to bring context to the metrics in OB? Next slide. So I want to highlight a cautionary tale with the use of metrics that comes from the United Kingdom. And I think that there are likely people from the UK on this call who are even more familiar with this case than I am, but this is definitely a cautionary tale that we should learn from. So the Ockenden Review or Report, which was published in 2022, this is named after the lead independent midwife that investigated this particular case I'll be talking about. So previously in the UK, the cesarean delivery rate was used as a quality metric that was monitored, and a lower rate was assumed to be associated with higher quality or optimal care. The particular hospital in question, the Shrewsbury and Telford Hospital, boasted a cesarean delivery rate that was approximately 10% below the national average. A series of safety events, including neonatal and maternal deaths, sparked an investigation and this Ockenden Review. Next slide. This has been described as being the UK's biggest maternity scandal. The Ockenden Review revealed that at least 201 babies could have survived if the Shrewsbury and Telford Hospital had provided better care. In other cases, mothers died and babies were left brain damaged. So a critical issue that was highlighted in the report was the hospital's misguided aim to maintain a very low cesarean delivery rate. There was extreme rigidity in keeping this rate low, which was thought to have led to avoidable harms, and the metric itself was prioritized over the patient needs. After this report, the NHS has actually discontinued using this rate as a quality metric, and this is just a very somber example of how an unbalanced focus on the number, the metric, without considering the context, the patient needs, and balancing measures may lead to detrimental outcomes. So we know that there is a safe range for cesarean delivery rates, and that lower isn't always better. We see benefit to the maternal health sort of plateau around 20% and really, really sharply increase when we fall below 10%. So how could this information or this metric have been used more responsibly, and what lessons should we as OB anesthesiologists learn going forward? Well, we have to take the context into consideration, and this was definitely driven home by both Drs. Landau and Dr. Zakowski when applying these metrics. One thing that we can look to is the levels of maternal care, and Dr. Landau just highlighted how this is correlated with the SOAP Centers of Excellence criteria as well, knowing that higher acuity patients should be delivered at higher acuity centers that have appropriate equipment and resources and workforce. The Joint Commission actually uses the levels of care in the context of their accreditation when they're actually assessing performance measures on hospitals. So this is just an idea that we can use when we're applying metrics as well. Next slide. Okay, so where else may this phenomenon of the context that we're using the metrics and the balancing measures apply? What are the balancing measures that we should be keeping in mind when we are trying to reduce a GA rate and assessing whether or not it may lead to more intraoperative pain, PTSD, depression, as mentioned in the previous talks? What about the failed block rates? Will too few replacements lead to labor pain, more GAs? Will this lead to more intraoperative pain if our labor epidurals don't top up well for cesareans? All very important things to consider when you bring these metrics home. So back to the North Star, we know that the maternal health crisis is particularly targeting certain populations, certain vulnerable populations. The MMR of a Black woman in the US is similar to that of a low-income country, and it is much, much higher than our white counterparts in the US. So we have to remember, as always, that we need to be applying to an equity lens whenever we do any work in obstetrics, but this is particularly important for the quality metrics that we're talking about today. So here is another example of where we might need to use caution with our metrics, particularly when it comes to our vulnerable populations. So the NTSV stands for the nulliparous term singleton vertex cesarean delivery rate. This is akin to a lower risk cesarean delivery, and it's a common metric that is followed for accreditation, and it's also used for a lot of the pay for performance programs. So a lot of these programs involve government-funded Medicaid programs in hospitals that largely treat patients who don't have private insurance. Hospitals are incentivized to have a lower NTSV cesarean delivery rate, and there is a national target that has been set that we are meant to achieve. So most of you are likely familiar with the Obstetric Comorbidity Index. This summarizes the maternal comorbidities that are associated with severe maternal morbidity into a single number that we can prospectively identify women at high risk and attempt to anticipate more appropriate care. The OBCMI actually purposely has excluded race, ethnicity, socioeconomic factors in their risk assessment, all the while knowing that they are very much associated with higher maternal morbidity. But they did this so that we could actually assess other markers of maternal morbidity in a way to get insight into these disparities. And this is a nice tool to use in this example. Next slide. So we know that even with risk adjustment, patients who are not white have higher severe maternal morbidity. Similarly, patients who utilize government insurance programs that I was talking about in the last slide actually have higher rates of severe morbidity when risk adjustment is applied. Next slide. So let's use this tool and apply it to the NTSV metric. We can see that with a rising OBCMI index, so this is a marker of severe maternal morbidity, the NTSV rates really skyrocket. And this is really, really exemplified in all of the non-white groups that this particular study looked like. So it's an interesting tool to be able to use this for these different metrics, and it might be something to look into when we're applying these metrics at home for particular populations. Next slide. When it comes to using NTSV in pay-for-performance programs, for example, will groups who have a higher NTSV rate be punished by not getting the funding that they need? These are the groups who utilize government-funded programs disproportionately. We haven't got to the root cause of the disparities that drive this difference in maternal morbidity, although we do know that racism is a big part of it. Is it fair to apply this metric in these types of programs? So we must use our equity lens to consider the impact that this may have on vulnerable populations. Next slide. Just a note on the interpretation of our data. We don't have a lot of guidance in the analysis and interpretation of our quality insurance data currently, and it's not associated with the metric statements that we've seen. Next slide. So we do need to be careful about how we analyze this and whether we can use our traditional methods in statistics or whether we should pivot. So here's just an example of our pre-post analysis bar chart that we often use when we're looking at interventions. We can see that it looks like there's a very impressive change that we've made. Next slide. But there may be a story behind the scenes. So maybe our interventions did make a difference, or maybe things were getting better anyway, and we just kind of caught caught it on the tailwind. Maybe we actually made things worse, but the snapshot of our data we caught before it bottomed out. Maybe we did make it better, but maybe our efforts weren't sustained, which actually sadly happens in a lot of quality improvement projects. Next slide. So this is where investing in personal skilled in statistical process control, SPC, which is kind of the statistical method that is particular for quality improvement. This is where it's going to be really worthy because this is meant for metric analysis, looking for trends, and meant for quality improvement work. Next slide. So the primary tool in SPC is the control chart. Interestingly, this is what the Joint Commission actually also uses when they're monitoring our performance metrics. It tells a better story. It allows us to follow our data sequentially and not just look at it in this before, after, pre-post kind of erroneous way. Next slide. I just wanted to take a moment to comment on AI here as well, because we really can't talk about anything in healthcare without mentioning AI. The IHI has recently made a statement about use of AI in quality improvement. It's definitely a tool that is going to change the ability to harness data. One thing that I suggest that we really use it for is applying it to the nuance in our patient populations and institutions, as we've all been highlighting all along. Next slide. And then the last idea that I want to leave you with is once you have your metrics, once you've built your dashboard, once you've been following this shouldn't be the end of your quality improvement work. The data shouldn't be the end of the story. This really needs to be This needs to be the spark that gets you going with your quality improvement projects so that you can analyze the processes and systems, use small tests of change, and apply the continuous improvement science to get to your end goal. Next slide. Just a reminder that the CMQCC, which I mentioned before, has these quality improvement toolkits, which are available. If you make an account, they are free. Next slide. And the Alliance for Innovation in Maternal Health, it's another multidisciplinary group that has patient safety bundles with similar success stories as well to the CMQCC. These are also freely available. Next slide. Just a plug for investing in clinicians that are skilled in quality improvement methodology. Sometimes because QI was born of manufacturing and industry, it fits a little bit awkwardly into academic medicine. We haven't come to a consensus as to whether any program or methodology is best, but we do know the common factor amongst all of them is that it is meant to be a continuous and cyclical process. So it's not something that should be a one and done. We need to keep following up on these projects, following up on our data, and ensure that they have longevity in order to make impact. Next slide. Recall that the metrics that were presented today are largely expert recommended. They definitely come from evidence and data, but there definitely is a point to finding metrics that might be important to you. You should be empowered to determine what's important to your patient population, your institution, and to design your own metrics and projects around those. And I have a couple of examples coming next. So Dr. Landau actually published this paper after Roe was overturned here in the US, and her co-authors outlined some action items for US anesthesiologists who are passionate about reproductive health, particularly surrounding Sugammadex consent, efficiency and promotion of postpartum tubal ligation, and pre-op pregnancy testing. And this is actually something that we've used at our institution with our learners to spark some QI projects. Next slide. Me personally, I am very passionate about blood product stewardship. So following transfusion rates, wastage rates, optimizing the workflow surrounding our MTGs. This is something that we're working a lot on right now at our institution. Next slide. So in summary, ensure that context is taken into consideration when you bring these metrics home. Use an equity lens whenever you are interpreting your data or applying these metrics to goals and outcomes. Interpret your data safely and definitely invest in the people and the tools that will allow you to do that. And please ensure that the data isn't the end of the story. Start with QI projects, even small changes. Use the toolkits that we've talked about today, and please disseminate this for the greater good by publishing this as well. And two last slides here. 17 years is the average time between the description of an effective and evidence-based intervention and large-scale uptake into clinical practice. This is known and often quoted in improvement science as the evidence to practice gap. Next slide. This just fits too beautifully. So Dr. Nanke published his work on the prevention of hypotension during spinal anesthesia for cesarean delivery with phenylephrine in 2005. And in 2022, we saw recommendations surrounding this made by the ASA Statement on Quality Metrics. And this is exactly 17 years. So just fit too perfect not to mention this. Thank you very much. And I think I will hand back over for our Q&A.
So I'm happy to take the first question in the Q&A box. Dr. Hendra was asking about the epidural failures and the epidural replacement rates and the 3 to 6% range, which seems quite high. Where does this number come from? And shouldn't we be setting a higher bar for quality of neuraxial blocks? Thank you for this excellent question. Obviously, we are setting the highest bar possible for the quality of neuraxial blocks, but we do know that sometimes despite tweaking an epidural catheter, there are catheters who will not provide adequate analgesia, or catheters that fall out, or there are issues. So the question, where does this number come from? I actually showed it in the slide. This came from reviewing the little data. There's not much data there. No one likes to talk about one's failures, but there were 4 institutions that reported their data. And although it seems like it might be a little bit older data now, one was from the Brigham with a pretty high rate. And then there's one from Wake Forest, which was right in the middle of this range. And then a lower rate from Singapore, from Ban Leon Snug's group in KKH. And there's a 4th one. It's a little bit all over the place, but we decided to go, as I mentioned, with a sweet spot. Having a center tell us that they never have any epidural catheter fail and that they never replace it, which we recently had, doesn't seem realistic. We actually don't believe that it's possible. It's like people telling us that they never need to convert for general anesthesia in a patient who either has pain or an issue or prolonged duration of surgery. There's always, those cases that require an intervention, and 3 to 6 might seem high, and it's possible that we might decide to reduce it. But right now, based on the available data, we wanted to offer a range so that people were aware. And it's not so much about the number, again, it's about the process. It's about make sure that you check that your epidural is working, make sure that you identify early on the possibility to make it work. And if it doesn't, be humble and replace it. And again, it's not the number, it's more the process and the reporting system so that institutions would know what their replacement rate is. There were many institutions initially who said they didn't have the information. And it was a way for us to raise awareness around the need to round on patients and to report these replacements.
I would just extend that answer. I agree. I tell my patients the replacement rate is on the order of 1 in 20. And so they know up front that if we want to maintain a really high quality block, we're going to be replacing a number of them. But you can treat this as a balancing measure. So if your conversion rate to general anesthesia is quite low, you'd also have to measure the quality of that anesthetic. If folks are happy with their intraoperative anesthesia with the epidural catheters and the replacement rate is low, that might support a lower epidural replacement rate. I think we know that there's some tricks you can do in terms of perhaps CSC has a lower replacement rate, perhaps taping on the side for patients who are have a high BMI can reduce the replacement rate. But even with all of those tricks, the quality of the blocks will require replacement in order to get optimal labor analgesia and a very low requirement of conversion to general anesthesia.
And the intra-op pain, right, it's a big deal too. With ASA has a statement on pain during cesarean, which everyone should go check out. And as well, we're working on a statement that was submitted to Board of Directors and House of Delegates for approval this October about use of adjuvant medications during cesarean section, so that you'll have a guide, again, nothing required, meant to be helpful, so that, oh, these are commonly used, even if it's not specifically FDA approved, which very little that we use is, and includes alpha-2 agonists, opioids. So look for it usually it's November by the time it's posted on the ASA website. But again, intended to help you and to normalize the fact that you may need to use something.
So we have about 5 questions on here, and I think we'll go ahead and discuss all of them. I know we're at the end of the hour, and as folks need to certainly drop off, but we will stay on and talk through some of these questions. The next one relates to general anesthesia rates for cesarean delivery and how it is defined. What cases are included? What cases are excluded? What do we do when patients need to return to OR for hemorrhage? A placenta accreta syndrome would be another case where we might start the case with neuraxial and intentionally convert to general. Who wants to talk about that definition?
I'm happy to take it because this is such a good question. And again, it's not an absolute number, and that's why I'm saying the process requires nimble and humble, how should I say, question. So in the COE application, I don't think I ever mentioned it, but there are actually 120 questions. Some of them are open-ended, and some of it really have subtitles as to tell us what your general anesthesia rate is for emergency C-sections, scheduled sections, and we specifically say excluding the complex surgery and excluding the placenta accreta syndrome patients. So obviously, if the patient requires it because there's hemodynamic instability, then the institution has the ability to mention it. And when it's not clear, or we're not sure we understood the answer, or we're not sure that the question was answered in a way that we can interpret the results, we go back and forth. So the rate, again, is not an absolute number. It is sort of a reach, it's a target, but there are institutions where it might be higher, and it is what it is because there's no other choice. So an institution, and it was mentioned in on one of the slides, where the epidural analgesia rates are low, then patients are more likely to have a general anesthetic. Now, if it's in the middle of the case and that there's a conversion, the recommendation is to actually indicate why the case is converted. So I can speak about our QA process at Columbia. We have integrated in our electronic health record when there is a case that is converted in the middle. So there's an epidural that is converted, or spinal that is converted to a GA. We cannot close the record without indicating, and it's a drop down, why the case was converted to general anesthesia. And that allows us to review our cases. And this is exactly what the SOAP Centers of Excellence is promoting, is having a quality assurance program surrounding these unexpected outcomes. The conversion of a neuraxial to general anesthesia is not expected, and there should be a process to review and see what could be improved. And these are the things that we're asking. We're asking for the quality assurance process. And in rare circumstances, we have actually not given the designation because we felt that there was still room for improvement. And we were asking, what are the things that you plan on working on? And these were our suggestions. And the center comes back the next year with an improvement, and then they get the designation. So again, it's a journey. It's not just the number.
Well, and you highlighted the valuable use of our EMR build and really strategically putting prompts in to kind of prompt behavior, but also to ensure that we're getting definitions and data out that is what we think the data is saying. And oftentimes the subtleties of the case is more complicated than looking at a very, very high level. The next question has to do with pay for performance and the risks of that. I think Kelly touched on that a bit, recognizing that we don't know how our measures, how we may harm our patients. How often do you advocate for a review of the metrics utilized, especially those used for pay for performance? I would say that very little of what this group talked today has made it all the way into pay for performance programs. And I think that's because of the purview of the payers and the government agencies and the external agencies that are ranking hospitals is at such a high level that they are interested in the measures that span across the health system. So I used to think that it was unfortunate that our subspecialty didn't receive that level of scrutiny or honor, but now I think it's probably beneficial. That being said, CMS in 2022 had opened a measure, I think it's a national quality strategy with a process to select, monitor, recommend measures. And there is in their 170 measures that they're recommending a measure for maternal safety that they link to the measures recommended by the Alliance for Maternal Health. So as you are working within your groups, I think figuring out how to allocate your QI energy resources and to divide that between making obstetric anesthesia excellent and really pushing forward maternal safety metrics that might be measured externally will depend on what external pay for performance systems are in place at your facility. But does anybody else want to take a stab at that question?
I think you answered it better than I could have. I was just echoing that it's on such a high level, way up in the CMS, the Centers for Medicaid Services. So definitely, you know, another place for physicians to be climbing up the, I guess, political or advocacy ranks there. But you know, I think it is reviewed at least on an annual basis largely, but it's definitely someplace that we should be pushing forward for a spot for advocacy.
Yeah, well, I mean, so the initial pay for performance, which was a big deal, was over 10 years ago, and that sort of wasn't quite as popular as some people expected. And currently it's more along the line of complying in the US, trying to do the MIPS. And there is a committee, CPOM, Committee on Performance and Outcome Measures. And we did submit some this year to CMS for potential acceptance. So that they did that with input from my committee, the Committee on OB Anesthesia. So there is stuff, but it's really going over sort of the smaller items. We'll see if it gets accepted or not.
And, you know, if you go to the CMS website, that national quality strategy talks about the processes by which the measures undergo continual review. Usability is a criterion that we haven't talked a whole lot about, but a few of our presenters gave illustrations. And that's the concept that a quality measure is out there, it is in use, and it is being used to drive forward improvement towards those 6 domains. And so demonstrations of improvement then provide a form of validation and highlight opportunity to push measures forward into some of these higher stakes applications. Well, let's talk about postural puncture headache. let's see, which one is increased? Unintentional dural puncture or weak management of unintentional dural puncture. Okay, so when we think about monitoring the whole portfolio of measures for dural puncture, what should we be focusing on? Should we be focusing on PDPH? Should we be focusing on unintentional dural puncture rate? Or should we be focusing on the management? And I think one could focus on any or all of those. I'm curious if any of you have tackled this in your institutions or have advice.
So I would
I can-
say reducing the likelihood of an unintentional dural puncture is important, or even an intentional dural puncture with a needle that is likely to cause a post-dural puncture headache. So I want to first refer everyone to the excellent ASRA-SOAP interdisciplinary, multidisciplinary practice guideline that was published last year in several journals with a commentary and an editorial in regional anesthesia and pain medicine. So first of all, reducing the likelihood of a dural puncture with a needle that might be resulting in a headache, then having a process in place to follow the patient who did have an intentional or an unintentional dural puncture with a headache. And I think my reading of the consensus statement was that these are the processes that need to be robustly put in place, because the dural puncture can happen. It is what it is. But what is not okay is the poor management of and the poor follow-up of these patients, knowing that these are associated with potentially serious neurological complications. So again, continuum of care, it's not a number, it's a process, but having the way to follow these patients by someone who understands that that was something else that came up in that consensus statement is you can't just expect the GP to be following the headaches. They don't have the same appreciation of what to look for, and also to send, particularly for obstetric patients, not to send them to an emergency room, but to have them followed up by whoever performed the neuraxial procedure is something that I think would qualify as excellence in care and not just care. So I think the continuum of care and fixing the complication by someone who understands the process is key.
And I think
Yeah.
that SOAP COE application reflects that. So the high level metric is the unintended dural puncture rate being less than 1%, but then there's sub questions about those follow-up processes that you described.
Many questions.
And as well, ASA, my committee, the year after we did the post-dural puncture headache statement, we did like I call it a toolkit, but it has like a template for a note to go see someone who is complaining of headache, a patient facing handout, and then some like a checklist on how to do an epidural blood patch. So I put the link in the Q&A, but you can find it under the Obstetric Anesthesia Committee on the SOAP website.
Something we've talked a lot as a group since I think this topic has sort of evolved over the past 10 years or so is also the consent process with patients as well too. And where a headache was mentioned, it was briefly described as something that was treatable and something that was acute and not chronic. We've, particularly for certain patient populations, have evolved our consent process as well with that too, which I think is definitely a marker of quality care when we're using the newer data that we have now to better kind of advise our discussions with our patients.
That's great. Our last question has to do with neuraxial dexmedetomidine and whether that could decrease the neuraxial failure rate during a cesarean delivery. I am able to give dexmedetomidine intravenously, and I think it certainly provides some supplementation. I do know there's data to suggest alpha-2 agonists can function as an adjuvant, particularly for visceral pain. But I'm curious if anyone has any thoughts. Should we be adding dexmedetomidine to our neuraxial anesthetics?
No, I'm nodding my head because I have thoughts, but not because I'm advocating for adding it to the Neuraxil. So actually, I don't know if you remember, I presented on that topic at the last SOAP annual meeting on a panel on Neuraxil adjuvants. So I happen to know the literature. So first of all, it's an absolutely off-label drug. So that's the first thing. There's no black box warning, but it's an off-label. And if it were to be used, I would start by saying, be absolutely certain that you're using the preservative-free formulation, because not all of them are. So if there is no indication that the vial you're holding in your hand is preservative-free, don't give it Neuraxil. Now, has it been used around the world? Definitely. There are numerous studies. There's even a systematic review and meta-analysis on its use. It's mostly been used in China. The dose, because I know someone will ask, is 5 micrograms. I have used it on very rare occasions and very cautiously. I can't tell you whether it decreases the Neuraxil failure rate, because there was no failure rate that I was trying to reduce. I was trying to improve patients' experience. I can tell you it works well, but there's no strong data and there's no randomized controlled trial comparing it to other methods other than placebo, like not adding Precedex. So I cannot recommend its use, but it has been used, it has been reported on, and I have used it on rare occasions.
And as usual, I agree with you, Ruthie. I just reviewed this for a talk I'm giving next week. But yeah, if you search for it, there are several studies now that talk about dexmedetomidine, epidural PCA, IV PCA is complementary to the C-section, post-op, intrathecal. So the evidence is pretty good, I think, suggesting that it would be helpful, and it goes with sort of what I call the general plausibility, what we know about alpha-2 agonists in general and mechanisms of action. But do be careful since it's not widely used.
I think we can close with that, and just the key point that we really should be listening to our patients. And many folks will ask about or frame pain in terms of pressure and ask if the patient's feeling pressure or pain. And the more we learn about it, the more we come to realize that pressure can be painful. And it's really our patients that need to tell us if they are feeling pain or if they're feeling pressure that is so intense that it is pain. And dexmedetomidine might be one solution to reduce that, but going to sleep is not always the wrong answer. It is sometimes the right answer. And as Kelly alluded to, if we are so focused on our outcome measures of, say, avoiding general anesthesia, we can actually be introducing harm. So the right numbers are somewhere in the middle, and I am interested in really learning more from the practices that are applying for COE and other research submissions that I encourage groups to submit to anesthesia analgesia to really evaluate quality measures, reliability, validity. We talked about usability today, and to illustrate how those measures can drive forward our quality aims.
And even just, pick something and use it, and you'll see you can measure where you are and how you can move it forward. Doesn't matter what they're doing necessarily at the named places. It's how you can improve things at your institution.
Well, thank you. Thanks to each of you for presenting today, Drs. Fedoruk, Zakowski, and Landau, and thank you all of you for your attention.
Thank you.